Good evening, everyone. So, myself, Dr. Jagan Sivalingam. I'm a fellow of DCB Academy. Currently, I'm working as a consultant cardiologist in Hannah Joseph Hospital, Madurai, India. So, I'm going to talk about management of calcific coronary lesions. This is going to be the outline of my talk. So, first, we will see the clinical implications of calcific lesions. Then, how are we going to image? What are the various imaging modalities available for calcium? Then what are the various techniques available like balloon based techniques and other ablation methods, then the algorithm or approach to coronary calcium, and finally a couple of case examples, then conclusion. So coming to the clinical implications, why are we bothered about calcium? So as we all know, calcium is in like coronary angiogram in approximately 1/3 of patients. So, but if we use a different modality like IVAS or OCT, the numbers go up. And the risk factors of coronary calcium is elderly males, hypertension patients, CKD patients. Calcium is calcific lesions are associated with reduced success rate of PCI, and it also increases the stent malapposition and under expansion. So, which in turn leads to ISR or stent thrombosis. Also, it is associated with acute procedural complications such as edge dissections and perforations. So, we have to appropriately modify, debulk the calcium before stent implantation to achieve optimal outcomes. So, how are we going to achieve this? The first and foremost thing in calcium management is proper and detailed evaluation of the calcium. So, there are various imaging modalities. So, the plain angiography and other things such as intravascular ultrasound and OCT and cardiac CT. Today, I will emphasize upon IVAS and OCT because cardiac CT it's not readily available in many places, and also it's mostly used in the management of like CTO. It requires much time and expertise. But IVAS and OCT, if available in the cath lab, we can readily use it. So that's why we'll emphasize on IVAS and OCT. So angiography, as we all know, it's not as sensitive as IVAS or OCT. So its sensitivity is around 1/3 only compared to IVAS and OCT in detecting the calcium. So this table compares the various imaging modalities and the diagnostic accuracies with respect to calcium. So as I told earlier, when there is mild to moderate calcium, so angiography is not as sensitive as compared to IVAS or OCT. So OCT is definitely better than other modalities in detecting the mild to moderate calcium. When it comes to severe calcium is defined angiographically as calcium is seen on both sides of the vessel wall with cardiac motion, and with plain fluoro itself we are able to see the uh, calcium. So that means it's severe. So when it's visible in plain fluoro itself, we are calling it as severe calcium by angiography. So then it's obviously it will be readily visible by IVAS as well as OCT. One thing is deep calcium. So deep calcium is where IVAS scores over OCT because light is not able to penetrate deeper. Sometimes it is difficult to image the deep calcium with OCT, whereas the sound waves will travel much better and it gets reflected. Deep calcium can be detected by IVAS. But when it comes to the calcium thickness, we are not able to measure exactly the calcium thickness using IVAS because of the reverberation artifacts. But IVAS we can, sorry, OCT we are able to measure the calcium thickness. So, and also longitudinal calcium length, OCT scores better than IVAS. And one point where IVAS scores over OCT is the non-homogeneous block. That is, if there is a thrombus and there is underlying calcium, then the light in OCT is not able to penetrate into the thrombus. So in that case, we may not be able to accurately see the underlying calcium. So from this table, we see OCT is definitely much better than IVAS in various aspects of calcium imaging. So now we move on to the comparison of IVAS and OCT. How does calcium look like in OCT and IVAS? So this is the first image A. Here the OCT we are able to see a hypoattenuated, well-defined this thing. So this is superficial calcium and it's also extending into the media and reaching the adventitia. So here exactly we are able to measure the thickness using OCT. Whereas the corresponding IVAS image, we are seeing a hyperechoic image, but beyond that, the sound wave is not able to travel. It gets deflected from this hard calcium.
Yes,
So
briefly,
it's
calcium,
all black.
calcium by OCT is black and is well demarcated. Okay, it's just like a nodule, and in IVUS it's white, and it's typically white. And as you said, it is very important. The thickness of the calcium is difficult to understand with IVUS, and it's easier with the OCT.
Yeah, thank you. And this is another example of deep calcium. Here we can see the hypoattenuated, well-defined borders, whereas it's hyperechoic, and beyond that we are not able to see anything. So definitely OCT is much better tool for quantification and detailed evaluation of calcium. So now we move on to the various scoring systems available. So there is the IVUS calcium score as well as OCT calcium score. So this IVUS calcium score, there are 4 points. So presence of calcium for 270 degree and above arc. So this is almost like 270 to 80 degrees, and this should be present for a length of more than or equal to 5 millimeter. Then second parameter is 360 degrees. So this is like complete circle, 360 degree of calcium. Third point is calcium nodules. So here we can see the nodule. And fourth point is
it clear to anybody what does it mean 360 and 270 degrees? So is this clear to anybody? All right. Yeah, seems clear. So please proceed.
Fourth point is vessel diameter less than 3.5. So each carries one point. So this was actually a retrospective study. From this, what they found out was if the calcium score is more than or equal to 2, then usage of atherectomy yields better stent expansion and good results. So suppose if there is calcium nodule, it gets 1 point, and the vessel diameter is less than 3.5, it becomes 2 points. Likewise, if there is the 360 degree of calcium and nodule means 2 points. So anything more than or equal to 2 points means atherectomy yields better results, better stent expansion. That was found in this study. So similarly, we have OCT calcium score. So here it's also known as rule of 5. It's very easy to remember actually compared to IVUS. Like one full circle is 360 degree, half of that is 180 degree. So if the calcium is more than 180 degree, it gets 2 points. And next comes the thickness. So half 0.5 millimeter. So more than 0.5 millimeter, 1 point. Next length, it also 5. More than 5 mm means 1 point. So in this study, they found if the total calcium score is 4 points, then it was associated with stent under expansion. So this is very simple. It's also known as rule of fives because this is half 50% of the arc, more than 50% of the arc, that is more than 180 degree, and thickness is more than 0.5 and length more than 5 millimeter. So this is OCT calcium score. So then moving on to the strategy. So now we have imaged, then we have calculated the score. Then how do we select our tool? So this is the study from Dr. Rajesh Vijayvargiya, published last year. So here he divides the lesions into 3 types. First, he classifies whether it's a deep calcium or superficial calcium or nodular calcium. So if it's nodular calcium, straight away he tells to use ablative techniques, either rotational atherectomy or orbital atherectomy. Then if there are no nodules, then the calcium is superficial. Then we look at the score. If it's 4, that means there is more than 180 degree and thickness is more than 0.5 and length of calcium is more than 5 millimeter. Then we move to the next step, whether are we able to pass a balloon or not. If the lesion is crossable with a balloon, then we can choose, there are various options available, intravascular lithotripsy or ultra high pressure, that is open NC balloon, plus or minus atherectomy. So if the balloon is not crossable, then we have no options. Then we have to use ablation only. Then rotational atherectomy or orbital atherectomy. Then depending upon further, we can use other adjunctive techniques like IVL or ultra high pressure balloon. Ultra high pressure balloon. Okay. So, but if the calcium score is less than or equal to 3, then we have to use NC balloon, like non-compliant balloon, cutting balloon, or scoring balloon. If the score is less than or equal to 3. So this is for superficial calcium. Similarly, for deep calcium, if deep calcium means it cannot be treated by ablative methods. So deep calcium score 4 means straight away intravascular lithotripsy. If it's less than or equal to
Jagan. Yeah,
yes.
Jagan, thank you. You just presented a concept and a suggestion by these physicians, but I have to say that this cannot be totally shared. So this is a point of view of some physicians. But for example, the ability of cutting balloon and scoring balloon and non-compliant balloon to manage, I would not say only severe calcification, but also moderate calcifications are really lower than intravascular lithotripsy or rotational atherectomy in case of calcium present well deep in well within the lumen. Okay, where rotational atherectomy or orbital can be the best choices.
They're much better. Yes.
So, yeah. So obviously, you have always to manage and also take into account the cost of the procedure and where you are performing it, because a scoring balloon is expensive, but it's much less expensive than IVL or a rotational atherectomy. So it is always a sort of balance. But if we have to choose the best tools are IVL or rotational atherectomy. With IVL, we have a few years experience, but great results. Rotational atherectomy, we started using it in the late 80s, and we have a huge experience. So these two techniques are really effective in managing severe calcifications.
Yes.
If we cannot use them, we can use, it's a downside. We can use these other techniques like cutting balloon or scoring balloon.
Yeah, sure. So now we move on to the various techniques, and I will be describing in detail about each technique. So broadly, we can divide the calcium modification techniques into either balloon-based techniques or ablation techniques. In balloon, we have various sorts of balloon: cutting balloon, scoring balloon, high pressure open NC balloon, or intravascular lithotripsy shock wave balloon. In ablation, we have rotablation, that is rotational atherectomy or orbital atherectomy, and laser. So balloon based techniques. So cutting balloon, there are various cutting balloons such as Wolverine, Flextome. So basically it's a non-compliant balloon with atherotomes or blades. So I'm talking about Wolverine. So Wolverine has 3 atherotomes, that is this blade like thing attached on the surface. So it makes cuts into the vessel wall. So it's around 120 microns. So the human coronary artery vessel wall thickness in LED is approximately 900 microns. 900 microns. So we are not worried about like direct puncture or perforation. So the advantage with this balloon is there is control lesion preparation and less trauma to the adjacent wall as compared to the other non-compliant balloons. But they tend to be bulky, so the downsides are its crossability and trackability are less as compared to normal balloon. So then there is scoring balloon. Scoring balloons, there are various balloons available such as angiosculpt or scoreflex. Here it is a semi-compliant balloon. So that is how it differs from the cutting balloon. So it has a scoring elements, that is we can see here. This is a nitinol wire which is woven around. This is angiosculpt balloon, whereas this is scoreflex balloon. So this nitinol wire acts as a scoring element. And here in scoreflex, we have the coronary wire. This is our guide wire, and this is the nitinol wire which is already integrated on the scoreflex balloon. So here there are 2 scoring elements in scoreflex. The advantage is because it's a semi-compliant balloon, there is low risk of melancering, that is slippage, and less risk of dissection. But
yeah,
the thing is,
the advantage of these devices are that they are much more deliverable than cutting balloon and trackable also, but their effect in scoring is lower than the ones that we can achieve with a cutting balloon.
Yeah, as well less efficacious, and they are more used in fibrotic lesions rather than primarily calcific lesions.
Agree.
So the primary indication is fibrotic lesions rather than calcific lesions. So then comes this super high pressure NC balloon, that is open NC balloon. This is very unique in design. It has a double layered like twin wall balloon. So it offers the advantage of going up to very high atmospheres like 35, sometimes even 40 atmospheres. So they claim it has no dog boning effect, or the dumbbell appearance won't be there. But obviously if you go to very high pressures, it can increases the risk of perforation and dissection. Then this is the shockwave lithotripsy. So this is a semi-compliant rapid exchange balloon with 2 lithotripsy emitters. So as we all know, this technology was evolved from the treatment of kidney stones. So like they tested in models with chalks and eggs, and they thought it will be, we can try in coronary artery also in the management of calcium, and that's how this was developed. So it comes in various sizes: 2.5, 3, 3.5, 4 millimeter diameters, but the length is constant, 12 millimeter. So it has two lithotripsy emitters. So we can see this is one and this is one, and these are the radio opaque markers. So it has a console and it emits the lithotripsy energy. Then the balloon is filled with contrast and saline in 1:1 ratio. So it creates high pressure supersonic waves inside the coronary artery, which generates up to 50 atmosphere pressure equivalent. So that it creates the cracks in the medial as well as deep calcium, and they say it's effective in nodules also. So initially it is inflated up to atmosphere of 4 atmospheres, then it can be inflated up to 6 atmospheres. This is the RBP. So per each inflation it emits 10 pulses. Initially it had 80 pulses, but now the latest C2 plus version has 120 pulses. So advantage is it's very user friendly. It has very short learning curve. It's like any other balloon, and less vessel wall trauma, dissection, perforation, and no slow flow. But limitations is it's also a bulky device. So tracking is an issue, and obviously it's very expensive. The cost is very high. So this video is just about the shock wave. So this is the pulse generator. This is the console. So here 80 is the total number of pulses, but now it has become 120. So then it's the, so we can see here they have shown 3 emitters, but coronary has only 2 emitters. Coronary balloon has only 2 emitters. So when this supersonic pressures are created, it gets transmitted through the medium of contrast and saline. One important point is there should be no air bubble inside this balloon. The preparation is very, very important because air impedes with the energy being effectively transmitted to the vessel wall. So we should be very careful that there is no air in the system. So this is the latest pooled analysis of various disturbed CAT studies. There has been CAT 1, CAT 2, CAT 3, CAT 4 studies. So approximately around 672 patients were analyzed in this pooled analysis, and they have given the following outcomes. So we can see any angiographic complications like flow limiting dissection, perforation, abrupt closure, everything is almost like less than 0.5%, and no reflow was 0%. It's very interesting. So now we have finished the balloon based techniques. Now we are moving to the ablation techniques. So rotablation is the gold standard and age and time tested method. It's there since more than around 30-40 years. So it is it is like a high speed rotating diamond coated burr. So this is the diamond coated burr. It starts in 1.5 millimeter, and there are sizes available up to 2 millimeter, 2.5 millimeter also. So the peculiar feature is the wire is 009 wire. The ordinary coronary wire we use is 014, but it needs a special wire, 009 wire, and it works on the principle of differential cutting. That is, it ablates the hard calcium surfaces, whereas the normal elastic coronary tissue doesn't get affected by this. And the ablated tissue debris is like the size of less than the RBCs, red blood cell size. It's ranging from 5 to 10 microns. So it is ultimately scavenged by our reticular endothelial system. And one important thing is the burr is to artery ratio. It should be 0.5 to 0.6. And the rotation per minute should be 1,35,000 to 1,80,000.
Well, 135 is really too low. There is a risk of entrapping the bar into the calcific plaque, so not less than 150. Hello? Hello? I cannot hear Jagan.
Hello?
Hello? Lisa?
Sì, io la sento, dottore.
Ah, quindi io ci sono.
Sì, anch'io.
Yeah, we lost Jagan.
Si è disconnesso, infatti.
Ok, doveva rientrare. Hello?
Okay.
Jagan?
Yeah. Shall I continue?
Yeah.
So now we move to the next ablative.
We need to you need to share again your presentation.
Okay.
So I was saying that I do not suggest to go below 150,000 per minute bar rotations, because there is a risk of entrapment of the bar. Okay.
Yeah. So now we move to the next ablative technique, that is orbital atherectomy. So this is different from the rotablation. That is, there is a single diamond coated crown. There is no various sizes available as in rotablation. This is only 1.25 mm eccentrically mounted diamond coated crown, and this is 6 French compatible, and it treats vessels sizing from 2.5 millimeter to 4 millimeter. We can use the same, but actually only one is available, and this has a specific wire known as Viper wire. So it ranges from 014, and it has various diameters according into the various parts of the wire. I will show it. And the mechanism here is similar to rotablation. It's called differential sanding. But one advantage is this is bidirectional. That is, during forward movement as well as backward movement, this acts. And the ablated tissue is very small. It's like 2 microns. And here the RPM is 80,000 to 1,20,000. As the speed increases, the orbit, the movement increases, and it reaches the vessel wall like this in like a planets orbiting. So this is the system. So this is the pusher, and we can see here the diamond bar is here. Yeah, this is the magnified view of that diamond crown.
No, we don't see it. You should put the presentation mode, because we are still stuck in the previous slide. Yeah.
Now, are you able to see?
Yeah, but not in presentation mode.
I mean presentation mode.
Yeah, probably you have shared another window.
I will close and come back again. Now are you able to see?
Yes. Okay. Yeah.
So shall I start with the orbital atherectomy?
No. Go ahead, because there is lack of time. Yeah.
Yeah.
Okay.
So
you can skip this. Yeah, you can skip this and go with the next. Yeah.
So next is a laser. It's examined laser coronary atherectomy. So this is actually approved in 1992, but it is mostly used. It was used in thrombotic lesions, and here it is the fiber optic cable, which has many laser emitting thing, and so it is available in various sizes: 0.9 millimeter, which is 6 French compatible; 1.4 and 1.7 is 7 French compatible; and 2 millimeter catheter is 8 French compatible. The same as like rotablation, the catheter vessel ratio is 0.5 to 0.6. And there are two settings which we need to be aware of. That is the energy, how much strong the laser is emitted, 30 to 80 millijoules per millimeter square, and what is the pulse rate, like 25 to 80 per second. So actually laser is used only when the microcatheter or wire is not able to cross the lesion. So how does the laser act? So it acts by three mechanisms. One is light pulse. It creates the breakage of molecular bonds. So, and another one is the sonic wave. So it impacts on the hot material and it changes the vessel's compliance, and it creates a vapor bubble. So the vapor bubble breaks down the material. So these three mechanisms are the how the laser acts. So then this is the table comparing the various ablative techniques. So rotablation, orbital atherectomy, and laser. So here we can see the risk of perforation and dissection is almost same with all techniques, but the slow flow or no flow is less with laser, and mild to moderate in orbital atherectomy. And one very important complication is burr entrapment, which is like it's not uncommon, but it can happen in rotablation. But burr entrapment is very rare in orbital atherectomy. That are the major differences. And 6 French compatible orbital atherectomy, whereas rotablation, depending upon the burr size, it is like 6 to 8 French. So now we come to the algorithm. So how do we decide? So first is on angio, we are seeing there is a high calcium content. Then we move upon whether it's able to cross, whether are we able to cross with a balloon. If we are able to cross with the balloon means, then we predilate and image. So OCT is preferred as compared to IVUS. So then we go to the rule of fives, the OCT calcium score. We calculate the arch, it's more than 180 degree or not, the length, then calcium thickness. If it's fulfill the criteria, then we move on to whether it's a deep calcium or superficial calcium. If it's a deep calcium, so it's IVL. If it's not deep calcium, then we can use either rotational atherectomy or orbital atherectomy. Suppose if these criteria are not fulfilled, then we can start with a non-compliant balloon, cutting balloon or scoring balloon. Then we reassess. Finally, if there is optimal expansion, then we proceed with stenting. So this is for balloon crossable lesions. So if we are not able to cross with a balloon, then we should be go to the next step, like whether it's able to cross with a microcatheter. Able to cross with microcatheter means we can exchange to the rota wire or viper wire, then do rotational atherectomy or orbital atherectomy. If we are not able to cross with the microcatheter, then we can try for direct wiring with the rota wire or viper wire. If nothing is crossing, microcatheter or balloon, both are not crossing, then we take the help of laser. Then finally, once again we reassess. Then it's like other steps. So this is the same table which I showed earlier. Now I will show few case examples. The first case is a 70 years old gentleman who had a cabbage in 1997 and a PCT-L6 in 2013. This time he presented with unstable angina. So this is the angiogram. So here we can see LAD is occluded and the lima is patent. So left side system is nothing much, but the point of interest is the right coronary artery. Here we can see RCA is heavily calcified. The whole vessel is calcified. So even before the contrast fills, we can see the tram track appearance. That is both ends of the vessel is visible. So it's a heavily calcific vessel. So this was actually attempted elsewhere and they couldn't pass a balloon. It was balloon uncrossable lesion. So this is a still image of the IVUS. So here we can see the 360-degree concentric thick calcium, and here in the longitudinal view we can see it's like the whole vessel is lined with a thick calcium. So we can see here. So it's fully calcific. So this is the non-compliant balloon. Here we can see the dumbbell appearance or the dog bone appearance. So this is the non-yielding point. So we decided to go ahead with IVL. So with IVL it yielded. So
you were able to easily cross the lesion with IVL?
No, we had to use initially NC balloons upsize. We started with 1.2 mm balloon, then 2, then 2.5. This is 3 mm NC balloon, which was having the dog boning.
Yeah,
then
that makes sense.
Yeah. Then finally we crossed, and then like usual angioplasty steps, and this is the final result with two drug-eluting stents, 3 into 3.8 post-dilated with 3.5 mm NC. So this is the final IVUS run. So for the sake of interest of time, I will just forward it. So it was a good result. So you can see all well opposed, and so this is second case.
In this case, it is mandatory to use imaging. So it was absolutely correct to use IVUS or OCT, whatever you want, but you have to understand how is the calcium, and according to that, decide which treatment to use. And then in the end, you can decide to place stents like you did, and then you have to assess in the end if the stents are well opposed and well expanded.
So this is second case. This is a 57 years old gentleman. He had multivessel PCIs some 8 years ago, normal LV function, and he presented with chronic stable angina. So this was the diagnostic angiogram. Here we can see the patent stent in LAD, and there was a ISR in L6 stent, and RCA was CTO. So we decided for RCA recanalization. So it was a bifemoral sound fringe access, AL1 for RCA and EB for, so it was a JCTO score of 2. So we can see septal collaterals from left to right, as well as a very big right to right epicardial collateral. So the plan was antegrade wire escalation first, then dissection re-entry. Third was retrograde. If not possible, then final option was epicardial collateral. So this is antegrade wire escalation. First Gaia third, then upon reaching the crux we de-escalated, then changing to fielder XTA. Then we checked in two different views, two orthogonal views, and made sure that we are in the lumen. Then the point of interest here is, so here you can see the dog bone appearance, like dumbbell appearance, how the NC balloon is not at all yielding. So here it's like constricted very much in the middle portion. So here also we started with 1.5 mm balloon, 2 mm balloon. This is 3 mm NC balloon. Then we took IVUS run. So IVUS, I will just go to the point of interest. So we can see here also almost 360-degree napkin ring like calcium. So then we decided to take rota. So we took a 1.5 mm burr. Vessel size was 3 millimeters. So 0.5 means we took 1.5 mm burr. Then after rotablation, so we found there was a very bad dissection extending till the crux. So immediately we fixed it. So we seal the distal point. Then this is proximal unyielding lesion. So we cannot obviously use rotablation again because there was a bad dissection. So we used OP and NC high pressure here. So here we can see yielding of the lesion. So we went up to 40 atmospheres here. So you can see how it yielded. So you can watch here. So it's the yielding. So it yielded. Then we fixed with another 3.5 mm, and then RPLB got uploaded. So I'll skip all this. So we recrossed, and then this is the final angiogram. So this is the final IVUS run. So it was all good result. So we achieved a area of 9.84 in the RCA. So coming to conclusion, so calcium remains the Achilles heel of PCI. It adds to procedural complexity and poor outcomes if not properly modified. We have a wide range of tools and techniques available. Imaging is mandatory, OCT preferably, and we can always use these are not exclusive, they are actually supplement to each other. Like now they are coining various terms like rotatripsy, which is a combination of rotablation and IVL, and laser, like laser and rotablation, etc. So to achieve optimal results. Thank you.
Thank you, Jegan, for Jegan. I should say
Yes.
Jegan, not Jegan. Okay, I always said Jegan, but now we start saying Jegan. Okay.
Thank you, sir.
Congratulations for this comprehensive presentation on calcific management. As I said last time, we could talk for hours about calcific management, but what is really clear is that this type of disease is one of the last frontiers in cardiovascular medicine, revascularization. If we give a look at 10 years data, one of the most important determinants of stent failure is calcific lesions. Severe calcific lesions are associated with a rate of TLF, which is double than the normal. So understanding them, as you said, by imaging very well, and managing it correctly with the tools that now we have is mandatory. I want to be very clear. If you have a severe calcific lesions and if you don't have a rota or IVL in your cath lab, you should not treat these lesions. Because if you treat these lesions, you just predilate them with no compliant balloon and you put a stent, that is associated with a high risk of stent thrombosis and stent failure. Okay, so this is an important message. I wish to thank you for this, and I would like to know if there are questions by the audience.
I don't have any questions. The presentation was very well put together and very clear to understand.
Thank you.
Thank you. Claudio, did you have the chance of viewing the previous presentation last week?
So I saw no, I only had time to see a portion of it. I lost the start and the end of the presentation, unfortunately. I was traveling, so I didn't have the best connection.
Okay. Yeah, but we have recorded it, so
yeah. I got the email, but I didn't have time to.
Okay, no problem.
Sorry.
Any question by the other attendees?
Yes, Bernardo, it's Pierluigi. I would like to ask Jagan if the choice of different techniques is also based on the cost and availability.
Yeah, exactly, yeah.
Okay.
Yeah, the availability is not so high. Rota, I don't know, but I have no specific data, but it's present in 60-70% of the centers, I think, in Europe, and maybe less than that, and IVL even less, because they are expensive tools. IVL, for example, I was in Latin America yesterday. Was there is present only in Brazil. There is in India, in few centers.
In India,
but also in Europe. Yeah. In India, Jagan, I think it's in few centers. Huh?
Yeah, in India, IVL balloon costs almost 300,000 rupees. So in that cost, we can actually finish a PCA itself.
Yeah.
With 2 stents.
Yeah.
So the cost of IVL balloon alone is 300,000 Indian rupees.
And you don't have a specific reimbursement, from what I know. But also in the US, it's $5,000, which for a single balloon is too much, in my opinion. In Italy, it's around 2,000 to 2,500 euro. So it's very expensive. Now we have in Italy a reimbursement, so we can use it easily. The reimbursement is covering the cost. But on the other side, you can manage almost all of the types of calcifications with these tools. So they are really good.
And if I remember well, also IVUS and OCT are not so widely available throughout the centers.
Yes, this is they are much cheaper, but the problem here is a cultural problem. Yeah. Because many physicians do not want to use them, even if last week at DSC there have been presented one big meta-analysis and other smaller studies, but still big studies showing how the outcome of PCIs after using IVUS or OCT is improved. So now the guidelines will state, the next guidelines will state this more clearly, but still the penetration is very low. Penetration of imaging is around 20-25% in the US and around 10% in Europe. Whereas in Japan, where they have a different mindset and approach to angioplasty and to, I would say, all surgeries, it's around 90%, 90-95%. So it's very different.
We're seeing that also imaging is so important in deciding what could be the procedure to be adopted and so on. So quite surprised.
It is very important at the beginning, as you said, and for final assessment if you put stents. So it's very important. But the difficulty there is not only doing it or not, but also doing it in a proper manner and being able to interpret the results. So not okay, let's do IVUS, okay, it's okay, this is the area, that's it. Yeah. No, because IVUS or OCT are important also for understanding the lesions, understanding the calcifications, how long it is, how thick it is, how many degrees are there. So it's not only a question of time, not only a question of cost, but also a question of culture and dedication and educational activities.
Okay, thank you. Thank you also, Jagan, for your beautiful presentation.
Thank you, sir.
Other questions? Not so far. Okay, so you are really comprehensive. Thank you, Jagan. Again, if you want to share the presentation to the team, to DCB Academy, just ask Jagan directly, and I think that you can provide them this slides like always.
I have got one question. Hello for everyone.
Okay. Hey.
Hello. Fine. Nice to see you.
From Poland.
Hello. Yeah. I have got a question. How many or who from you use the laser? Someone has experience.
I have not used
laser.
I don't have access. I have not used.
No, it's strange laser. I have no experience with laser. In Italy, it's present only in few centers. I was in India 1 month ago, or it was 2 months ago, and there was a session on complex lesions, and all of the cases were performed by laser, by different physicians. So I said, come on, here in India, everybody is using laser. But then asking that, they were very selected cases. So also in India, it's used not very often.
In Poland, we have got 2 centers which use laser. And we as a group performed a study comparing IVL compared to laser. And as I talked with one from a doctor who is in our group from laser part of the study, he told me that when we are doing PCI with laser in under-expanded stent, when we have got the stent in the treated area, later on we have to put the second stent in the same area. So we have 2 stent platforms, because when he began the PCI with laser in under-expanded stent and he did not put the second stent layer, he had instant restenosis in quite high percent of the PCI with laser. So it is quite important point of PCI with laser compared to IVL. We performed many PCI with IVL in under-expanded stent, and so far we did not saw such problems. So comparing IVL with laser, we have to remember that it's quite important to avoid instant restenosis in laser part, because we probably damage the polymer, we damage those stents,
and the drug.
And we have to put the second stent.
This is the point. Actually, IVL is also off-label if you use it just after implanting a stent, because also there we don't know if the polymer gets damaged or not. Even if, as you said, there are no reports of stent thrombosis, to my knowledge. So I would say that I don't have experience with laser, but using IVL as a bailout situation. If you implant a stent, you are sure you have prepared the lesion well, but in the end, the stent is not well expanded, it is more risky to leave the stent as it is instead of using IVL. So I agree that that's an indication IVL. Another one, even if this is not calcific lesions, but just the stent, acute stent failure.
Yeah,
thank you for your comment, Wojciech.
Thank you.
Okay, so if there are no other comments or questions, I have to get my airplane. So I say hello to all of you. It was a pleasure, as always, having you, like last week. And let's keep in touch, okay?
Thank you.
Thank you to everybody.
Thank you to all.
Bye.
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 Thank you, Prof.
Bye.
Thank you.
You.
Have a nice